We are online.
Good evening, everyone. I am Dr. Maunika. I welcome you all for today's session. And today's the icons in conversation with Dr. Ritu and the topic why everyone should know hysteroscopy. And I welcome Dr. Ritu Santwani, ma'am, MBBS, MD, FICOG, FIAOG, and AMRCOG. She's an obstetric gynecologist, IVF, founder and CEO 360 Degrees Healthcare Studio, Inamdar Multi-Speciality Hospital, Pune, infertility specialist, NUHS Singapore, co-founder, MAAM, board member of SWC. Ma'am, I welcome you for today's session and hand over the session to you, ma'am.
Yeah. Thank you, Dr. Monica. Dr. Monica, please, Saiti, please show the CV of the Sunita madam.
CV is not available now.
Why? I had sent you. Acha, okay, leave it. Hello, everyone. As we all know, the knowledge always increases by the sharing. So, friends, today, none other than Dr. Sunita madam is with us. Dr. Sunita ma'am doesn't need any introduction. For ma'am, usually person say that ma'am is pride of Pune, but I always say ma'am is the pride of India. Ma'am is known is a queen of the endoscopy. Actually madam doesn't need some introduction, but there is a formality, so I am completing that. Madam is the head of the department of the Ruby Hall. Ma'am is advisor and consultant at Dr. D.Y. Patil IVF and Endoscopy Center, Pune. That is one of the best centers. Ma'am is founder and medical director for Solo Clinic IVF, a center for excellence in infertility, Pune. Founder and medical director for Solo Stem Cells, a stem cell research and application center, Pune. Ma'am has lot of extraordinary achievements. Among this, the India's first stem cell baby and the world's first at the age of the 45 on 16th April 2018. Madam is past president of POGS 2021-2022, chairperson, founder, honorary secretary for ISAR, senior vice president in ISAR, president IH 2019-20, vice president for West Zone Foxy in 2015-17. Besides this, madam is the author of so many books. Yeah, thank you, ma'am, for displaying. So, madam is authored around 8 books and 29 publications, 60 keynotes and 37 orations, invited faculty to 23 international conferences. Madam is received as an icon of the year endoscopy. Sorry. Madam has received the Bharat Gaurav Puraskar 2019, Pride of Foxy in 2020, Best Medical Practices 2016, Best Citizen of India Award 2016, Glory of India Award 2016, Rashtriya Gaurav Award 2015, Sarvashri Award 2012, and Letter of Appreciation from the President of India 2012. So a very, very warm welcome to you, madam. Today, the madam is going. Yeah, ma'am, a very, very warm welcome to you. Ma'am, I want to welcome you with this lovely flowers. So, madam, you're muted. Ma'am, you're muted.
Thank you. Thank you, Ritu. Thank you so much. You are such a kind and a sweet girl we have in the city of Pune.
Thank you, ma'am. So, friends, as we all know, everyone has a lot of queries for the endoscopy. So, today I can say we are enough fortunate that madam, in spite of her very busy schedule, she has taken out some time. So today the madam is going to discuss with us a very important topic, that why everyone should know hysteroscopy. And later on, I will take some time again from the madam for the laparoscopy also. So madam, now the dais is all yours, because a lot of doctors have joined across the geography via YouTube. I'm getting already the messages. Yeah. Thank you, ma'am.
Thank you
so much.
First of all, thank you so much, Ritu. Thank you for having me. It's always wonderful to come on your platform. It is so much loved globally. You are always in a, way, want to give as much as you can to each and everyone in this fraternity. So thank you so much for having me. It's an honor to be here on your platform. Now, why I feel hysteroscopy should be known by everyone. First of all, hysteroscopy should become extension of your transvaginal sonography. Over the period, Ritu, when we did a post-graduation in 86, 87, 88, per speculum examination and per vaginal examination was our routine. After that, sonography, we used to do more of a per abdominal because transvaginal was not available. Sonography was never, so easily available or was so accurate. And unfortunately, they were not the days of endoscopy as well. So I know that many patients probably were undergoing unnecessary surgeries because there was no diagnosis. Anyone comes at the age of 40, straightway will go for a hysterectomy. We all are in the era of a save the uterus. We are in the era of minimal invasive surgery. So what we extended was per speculum examination, per vaginal examination, and then transvaginal sonography. And then came the 3D sonography. 3D sonography accuracy has increased. If you see the publication before with the 2D sonography, they were around 15 to 45% of the patient will still lose the intrauterine pathology, will miss the intrauterine pathology on a sonography. But with the 3D sonography, Fatemi's recent, it is a Fatemi's only previous publication. And with this 3D sonography in Fatemi's publication, still it is around 11 to 15% you will miss the pathology, whatever the excellent 3D sonography you do. Now, 3D sonography or whatever it is are the just diagnostic to help you for your provisional diagnosis. Any intrauterine pathology, the next step used to be dilatation and curettage to check the endometrium. And depending upon the endometrium, we used to decide. But if there is a polyp inside, somewhere at the corner, 1.5 centimeter, and I'm curating the rest of the cavity and doing, I'm not going to help that lady. And most probably, these ladies, the medical line of treatment was never successful because the pathology was never detected and the pathology was never treated accordingly. So the failure of medical line of treatment was also very high. At the same time, we used to miss a lot of early malignancy cases, even early tuberculosis cases, because the first sign will be the flimsy adhesion formation. They are very flimsy. Patient may not have oligomenorrhea, may not have subfertility, but they can be seen on hysteroscopy only. So only with the hysteroscopy, we try to become more accurate in a diagnosis. So the office hysteroscopy has made the lifestyle more easy. When we started with the 4 millimeter telescope, which needed a dilatation. So obviously it needed anesthesia, local plus sedation, or maybe a short GA. Over the period, understanding the advantages of hysteroscopy, the office hysteroscopy came in. What is office hysteroscopy? It means you do in the office. You don't need anesthesia. You examine the patient. You just put the patient's legs up, do the penting, and just put the office hysteroscope in. How we do the transvaginal sonography after the examination, just do the hysteroscopy. Now, ease of performing it helped us to do it more and more. One, because of the office setting, it became cost effective. Second, it was become easily available. You don't need a anesthesia. So your other risk for the, especially to the elderly woman, has definitely decreased. Now the next advantage is with the hysteroscopy, it is see and treat. So it is not diagnostic. So I go in with the patient for an intermenstrual bleeding. I go in, I see the polyp, I remove the polyp. Now 2 mm telescope also have the therapeutic sheath, by which you can pass on your scissors or the polypectomy forceps or the cannulas. So naturally, it became diagnostic as well as therapeutic. Now imagine a lady coming to you with 1-2 centimeter fibroid. You saw it on sonography. You might have posted her for a myomectomy. The job is so simple. You go in with the hysteroscope, you resect that myoma and you come out. Absolutely in 10 minutes, you cured the patient. Now, no other surgeries can be as fruitful as hysteroscopic surgery. So, naturally, I feel hysteroscopy is mandatory. Now, if you see the office hysteroscope, you just have to do the vaginoscopy. It means distend the vagina. You see the mouth of the uterus, that is the external os. With the fluid pressure, it opens up like a fish mouth. Cervical force take you to the internal os. And from internal os, you can view the cavity. So even if patient with the postmenopausal bleeding comes to me, even if she has an atrophic endometrium, I can see. Or if she has a borderline 6 mm to 8 mm, I can go in and see. We all know that only in 8% of the postmenopausal bleeding, it is a malignancy. The polyp is the most common cause. Imagine the stress for a lady with the postmenopausal bleeding when she knows that probably it may be a cancer. She comes to your cabin, you put the office hysteroscope after the sonography probe, you see the polyp, you take out, you know that probably it looks a benign. You can very well differentiate between the benign and malignancy. Though you will send it for histopathology, you know that you can assure the patient. So a patient walking in your cabin and getting relieved with the symptom and walking off in 2-3 hours with some diagnosis and relaxed mind, only hysteroscopy. Ritu, you are an expert IVF specialist. Many patients comes to you for an IVF. And you know that there are so many fertility enhancing hysteroscopic surgery that you can help and give them natural fertility. They don't need IVF anymore.
Very true, ma'am. Very true.
So patient might have one DNC before for a missed abortion. Now she's not able to conceive. You pass the hysteroscope, you found adhesions at the cornal end. You just took a polyp holding forceps also and you opened that with the cannula and you came out. Simple. And her fertility is reverse. So it is such a fruitful surgery or a procedure, I should say, the hysteroscopy is. Recurrent abortions. It's a T-shaped cavity. You just go in, give the lateral cuts, make the pelvis roomy. She has fruitful future pregnancies. So there are so many benefits and the ease with which you do. In 2011, when I was an infertility consultant, along with Dr. P.C. Mahapatra as a FOXY president, we run the hysteroscopy workshop across the country. We could reach to 50 societies. Out of, I think there were 190 societies during that time. And our project was called See One, Do One, Teach One. It means we used to show the case. Then me and Dr. P.C. Mahapatra used to call one delegate from the audience. We used to make him do one case. And then we used to call the another delegate. And the first delegate, we used to tell him, please teach him with you. So it is see one, do one, teach one. Why so easy? Because it's very simple. It's very simple to do the hysteroscopy. And that's why I feel, Ritu, it is a time where all of us have to learn the advances in a science, advances in a technology. I do believe that advances in technology are for the betterment of human being. It's for the betterment of a woman health. And it's always, I know every gynecologist, if
Bueno.
Saiti, please mute everyone. Saiti.
I think Palacios, I can mute her. I can mute her, don't worry. I muted her.
Okay, okay.
Small kids, but I appreciate at odd time she is still listening to us.
And
He,
he from the out, I think KSA, from KSA. Yeah.
okay, Palacios, I thought Italian. Okay, anyway, coming to the point is hysteroscopy is here to say technologies are advanced for the for the betterment of a human. And it's very important that we adopt to the technology. I'm sure every gynecologist in this country or on this global platform, if their mother or wife or the aunt or the daughter has perimenopausal or postmenopausal bleeding, they will never do the blind biopsy. They will always do, I will make sure also, they will always do hysteroscopy. If they are not expert, they will go to the expert and do. So I appeal everyone. It's very simple. It's not an expensive technology for every gynecologist to have in their cabin. I'm sure everyone owns one car. Minimum cost of the car is 5 lakhs rupees. The cost of these instruments, if you have a camera, the cost of this instrument is half the price of the car. So it's a mandatory to have. And in case if you don't wish to, ensure that you refer the case to your best friend nearby who can do the hysteroscopy and guide you how to treat the patient.
Very true. Very true. Very, very practical point, ma'am, you have shared. Yeah.
I appeal all of you. There is a global conference of hysteroscopy. It's a group, they all know who runs this. Alternate year, we do the conferences in Barcelona. Even in this April month, I represent India and I go there. It is a Sergio and Atelio and Alio. These are the 3 people who founded this GCH community, and we are nearly 1,500 from all across the globe. We meet in Barcelona alternate year for last 3 consecutive times. Only during the COVID pandemic, we had break. So we are meeting again in 3rd week this month.
Great, great, ma'am. That's why I always tell, you are pride of India, ma'am, not pride of Pune, pride of India.
But I want all of you to join GCH community.
Thank you, ma'am. Thank you, ma'am. Friends, meanwhile, if there are any questions, you can write in the chat box so I can take that questions. Ma'am, just a second, I'm checking on the YouTube. Sometimes the questions come directly on that.
We can have directly asking also.
Yeah.
Geeta Khanna is here. Hi, Geeta ji. Lovely to have you. Dr. Beena Naik. Beena, lovely to have. How are you, Geeta ji? She's a master of masters.
हाँ, Geeta ma'am, कैसे हो?
She is a pride of India. And it's an honor to have her here.
Geeta ma'am always joins my webinar. Usually she is always there.
Ritu, everyone loves you.
Ma'am, thank you. Your blessings. Ma'am, till we are not getting the questions.
You can ask anything.
Yeah. No, I'm not able to see any questions here. Ma'am, so the show's name is The Icons in Conversation with Dr. Ritu. So just now we have finished. Geeta ma'am is on the camera. Yeah, hi Geeta ma'am. Ma'am, good evening.
Good evening. Manaka, it was Ritu is my favorite. And whenever even Sunita comes, I definitely come here. And she get a very nice talk. Very good.
Thank you, ma'am. Thank you. Yes. Thank you, ma'am. Thank you for joining.
And
so, madam, as I'm
our passion.
Yeah.
Yes.
So, madam, we have just discussed the academic portion. Now I am going to shoot some questions which are the non-academic, and you have to answer in one word without taking or without thinking much. This is a surprise for everyone. I never tell anyone these questions.
Okay.
Acha, meanwhile, ma'am,
There is one question by Beena. What is
Yeah.
the scope of tackling cesarean section scar? Oh, fantastic, Beena. Fantastic. Now, this is such an important question because scar ectopics are increasing nowadays. Beena, hysteroscopically, you can go and you can gently, without the energy source, with the loop, that is we call is as a cold knife, you can take out that pregnancy very, very easily, gently. Now, two important things. Sometimes if it is very vascular, you can give a methotrexate and folinic acid next day, and 48 hours after methotrexate, you can tackle that so that it will become a dead and you will be easily taking out. Very rare chance of perforation when it is not done by the expert. So, but the important thing is when you are tackling it hysteroscopically, very difficult to repair the scar deficiency, that is isthmosis. So when you tackle this laparoscopically, I tackle it laparoscopically if patient is interested in future pregnancy. So I go laparoscopically, I take out that pregnancy, I make the niche very clear, the scar, and I suture it laparoscopically in two layers, the first layer and the second layer covering the first layer, so that there will be a strengthening of the scar. And I ask patient for 3 months to use a contraception, or in that case, avoid relation also. Now, if they are not much interested in further pregnancy, then I can think of doing it hysteroscopically. I believe that even if I do successful hysteroscopically, if she wants to plan the next pregnancy, there are chances that she can have a repeat scar or it may have a fundal insertion. But we can't afford repeat scar. And that's where I tell them you need a two-step then. Hysteroscopy and then later laparoscopically. So might as well I do laparoscopic in first sitting.
Thank you, madam. Thank you so much.
Thank
Dr. Nabila, Dr. Nasra, any questions? Dr. Nabila, you are from which country? If anyone is having a question, can unmute also and can ask the question.
Nabila Abbasi, I think.
Hello, I am from India, ma'am. Aligarh, Uttar Pradesh.
Okay, great.
Welcome,
great.
Nabila.
So till now there are no questions, I think. Yeah.
I then want to say something better. Just, because of my Foxy presidential elections, I'm moving across the country, and I met one of the endoscopic surgeon who had 3 cases mishap because of the fluid overload.
Okay.
So it is very important. I really appreciated him. And I said, it's important that you tell this to everyone because so that we remain careful. No, this generation or this era, no one criticize another. Everyone is open to tell what complication they did so that we all can learn. The lifetime is not enough to do on your own every complication. We all know. So another very important thing is we use now, especially in infertility patient, only bipolar.
Yeah.
Only bipolar energy source. But when they were using monopolar with glycine, the complication rate was higher because of the hyponatremia, brain edema, sodium imbalance, and also even the deaths. But don't think that you're using bipolar, that is, you're using normal saline. The problem is not severe. It is still, patient can still go into the fluid overload of pulmonary edema. So what I do is I always catheterize for example, I'm taking out 5 centimeter myoma. I will always take first the consent for 2 sittings. I never will do any operative with 1 sitting. So I will take 2 sittings, but I will try my best to do it in one sitting. When you take a consent for 2 sittings, you are at least mentally pressure. And these are the only cases where I accept when anesthetist says the difference in an inflow and outflow is more than 1 liter. Usually with 5 centimeter myoma, you can finish up very fast. But if the patient has multiple 3, 4, 5 fibroid, if you go on a YouTube channel, you will see 30 myomas, submucous myoma I took out. I don't remove my hand. I go in, I remove the pieces, all the myoma. I don't wait for the pieces to be taken out, because then the intrauterine pressure, you have collapse, lot of blood will come. With your hydropressure, these spaces will move. On YouTube channel, I have put up many these hysteroscopic surgery where a lot of tips and tricks I have shared. So these are the only cases where don't allow the fluid overload. Now, second important thing, what I do is I catheterize the patient. And when my anesthetist said, Sunita, already 700-800 cc, I tell her, please give a Lasix to the patient. 10 milligram, I give a Lasix because I'm using a normal saline. At least I know pulmonary edema I'm not allowing. And I make their anesthetic resident to keep on auscultating a respiratory system. So even if it is a 1 liter, 1.2 liter, 1.3 liter, I can just carry on little bit. But don't carry on beyond 1.5 liter with normal saline. You will land up in problems.
Yes.
How do you tackle bubbles? What dreaded complication you have made in your practice? How do you tackle the bubble? When the bubble comes, it means, one, you see that your inflow system is not a Y system. Y system mein kya ho jata hai? Your ward boy or the sister who is making the inflow on and off, the bottle is over. They did not pay attention and they did not start the new bottle in the Y system. The air has gone. The bubble will go. First is avoid going the bubble. Second thing is, if you are little bit patulous cervix, you can still have lot of bubble or the difficulty in maintaining the pressure. If it is the bubble because of the cystine coming and not because of this, I will keep outflow little on and intrauterine pressure at the high. So my pressure is maintained and the bubbles are getting aspirated. In early 2000, we used to use an instrument, bipolar energy source. First which came in India was a Versa scope and the Versa electrode. Versa electrode are the bipolar electrodes. Now, the only disadvantage of these bipolar electrodes were they cause lot of bubbles. And because bubbles, you get obstacle. So that time I learned to make, because every case I used to have a bubble, little bit outflow on, and then you will have the bubbles going out on your own. What dreaded complications you have? You know what, Bina? People say if you don't have a complication, it means you have not done enough practice. True. In my 30 years, only once I had perforation of the uterus. It was a Cox cavity, and I never understood when I perforated and I was watching nice yellow tissue. I know that I am in the abdominal cavity with the colon. Now, I always use the Caesar for a Asherman. So I saved myself because sometimes in a Cox abdomen, the bowel loops may be stuck on the fundus. And if it is the energy source you are using, and then you had it because you might have given that energy source to the serosal surface of the bowel. If it is a small bowel, then you might have perforated or passed, because large bowel has a thick wall. Small bowel don't have such a thick wall. Otherwise, Bina, I never had problem. Probably I simulate the case very much previous night, how I am going to tackle. I sit with my patients very much with all, you know, in Pune, we have a mapping with Dr. Manoj Chinchwadkar. So I go very, very methodically as if it's my first case today. And that's why you can ask my fellows of last 30 years. They will vouch for it that during their residency, they did not have any problem. Now, how do you tackle tight cervical stenosis? And what is your opinion regarding the use of intracervical pitocin injection? I give a local anesthetic. First is I put the misoprostol. All patients 2 hours prior, I put the misoprostol. The patient carries the tablet. When we book it, we write it down for her and she puts it because it's difficult to get otherwise misoprostol. So we give it from our hospital. Second important thing I do is in pitocin, I have never given, but I give a paracervical block to the patient. Third important thing is still it is tight. I cannot. Then I get a sonography machine. And under sonographic machine, I try and pass my Hagar's dilator, still dilator. Because on a sonography machine, abdominal control, I can see my still cannula going in very easily. And still if I can't, then I take an office hysteroscope. Because for an office hysteroscope, you don't need to dilate. And I see what is the passage going in. And then with the office hysteroscope, I enter the internal os and I move 3-4 times like doing a dilatation of a internal os with 3 number or 4 number Hagar's dilator. And then in that direction, I never face then the problem of stenosis. Dr. Anup Kapse, can I read Ritu?
Yes, ma'am. He wants to know regarding the lap and hysteroscopy training and share the platform to see all videos. I think that all are uploaded on Madam's YouTube channel.
No, not all have been uploaded. What we will do, Ritu, with you only, maybe after a month or so, I will take a hysteroscopy, being innovative in uterine cavity, where I compile all hysteroscopic 3 minutes videos and we will show it to all.
Okay, ma'am. Done. Yeah.
I will do that. Please share platform to see all videos and knowledge. Also, if you have a fellowship, please do let me know. Also, Anup Kapse, if you send me my number, you please write it down. I write it. 9822015850. This is my number. You WhatsApp me your number. I have a lot of knowledge groups where we share ebooks, we share interesting publication, we share a lot of new videos. So I can involve you into the knowledge group depending upon which state you belong. So they are state-wise knowledge group where we interact. And there are a lot of doctors, so we will do that. What is the scope of the use of morcellator? If you are asking for hysteroscopy, in my practice, gyroscope. I don't use all thanks to Stryker, but I think it is such an expensive machine to use it, that morcellator for a myomas of 2 or 3 centimeter. Now, I would show in my videos the 3 centimeter completely type O submucous myoma. You can just cut the base of the myoma with the scissor, leave the myoma inside. It will auto disintegrate in 3-4 days. You just give a tocolytic or antispasmodic to the patient. Binaji, I know you very well. You are from Gujarat and I have met you so many times. I know you. You are muted, Binaji. Unmute yourself.
Beena madam is usually in my all webinars from lockdown to
Madam Anup Kapse, you are from Chandrapur. Okay, so I'll put you in a Maharashtra Vidarbha group Anup. Your president, Dr. Manisha Ghate, she is probably the admin also of that group. You can talk to her and enter in, or I will enter you. You send me on WhatsApp your number. Yes, Binaji.
Hi. Yeah, how you recognize me?
Of course, I know you, Binaji, so well.
Yeah.
We meet
Nice to see you
regularly.
and meet you. Yes.
I'm coming to Gujarat Daura
When?
in June.
Okay, we will definitely meet.
First week of June, Baroda, Surat, Vapi, Valsad, that area I'm coming.
Okay. Welcome.
Madam is tremendously traveling, tremendous
And
effort.
Mahesh Gupta, I made him change his PPH date from second weekend to third weekend of June. So I'm there in third week of June. Today morning only I told him there is a AMOGS. Many
Nice.
people from Maharashtra will miss very important conference of PPH. And then he changed it to next weekend, today only. So you will get the announcement.
Okay, great. One more question, ma'am, we have received.
Yes.
Let me see. Yeah, just a second. Yeah, from Dr. Nasra Ahmed. Hysteroscopic polypectomy of endometrial polyps does improve fertility and increases the pregnancy rates in the previous infertile women.
Nasra, $1 million question, bacha. No one evidence doesn't say size of the polyp, number of polyps, and the location of the polyp, which are detrimental and which are not, unless two big polyp occupying the cornal openings obstructing. I still feel the sperms can move on, the patient can have an ectopic pregnancy. But on an average, if your polyp size is more than 1.5 centimeter, you can think of that it is hindering the fertility. But what I do, Nasra, is I tell my patient that I don't see any other cause of a subfertility. You have a regular cycle, semen is normal, you are young, your ovarian reserve is good. The only point I see is around 1.3 centimeter polyp inside. So if I remove the polyp and within 6 months, if you conceive naturally, retrospectively, I will say that the polyp was the reason why you were having subfertility, because this was working like an intrauterine device for you and a contraception for you. But otherwise, I don't promise the patient. I'll tell you one thing. Many a times patient has such a tendency of polyp. One school teacher was there with me. I did her polypectomy before the embryo transfer, just one cycle before, and by the time I started the preparation on day 12, I found a beautiful 1 centimeter polyp coming in. Believe me, I had done the hysteroscopy and I had removed her polyp. Now the thing is, this polyp has appeared in this just 3 weeks, 4 weeks because of the estrogen hypergrowth. I explained the patient that you have surplus embryos. I feel this polyp is physiological, and I would not like to cancel your cycle. Let me do the transfer. If I fail, then I'll remove your polyp again and I'll do. Being a teacher, she was very educated. She said, yes, please go ahead. And we did the transfer. We succeeded. That also tells us that 1 centimeter polyp doesn't come in your way. So I will be very cautious. Otherwise, also, I under-promise and over-deliver. I never tell patient, tum ye karo, you will get a success. I never tell that patient. I never promise. It's better we under-promise and over-deliver.
Thank you. Thank you so much, madam. Madam, before we wind off, I think again the questions are coming. Yes. This is a thank you message. So, ma'am, we all see you as a role model. So before we wind off, ma'am, can you please share some tips for the young budding gynecologist and how you are so calm, being in such a high spite of such heights, you are so humble, so humble. So, ma'am, please share some tips of your mantra.
I feel I'm very dedicated, very passionate. I'm very disciplined. I don't allow even the morbidity of a scar dehiscence. Laparoscopy, 5 millimeter scar, also I don't like it. I enter in the operation theater as if it is my first case and the patient is my mom. How carefully I'll work for her, I'll do the same with my patient. Second thing is I pamper my patient. I believe that they need to be pampered. Our hospital for us is a temple. They come to us with so much of a hope. I go to temple. Tomorrow is Hanuman Jayanti. I'll go to temple. I go with the hope that Hanumanji is going to listen to me, whatever busy the temple is. The same is whatever you're busy, your clinic or the hospital is buzzing, you still need to give attention to each and every one because they have come with that hope. And next important thing, Ritu, I know you are also very spiritual. I believe I'm also very spiritual. I feel every patient, I see that it is my Gagangiri Maharaj might have come in Dhar. I better work very hard and with honesty and with tremendous ethics. You know what? All youngsters should understand there is no lift to the success. It is the ladder you have to climb every day, one step at a time. You cannot say that I've started a practice and in 2 years I'll be on 100th of floor. You can't be. Second important thing is to climb with the lift. In 2 years to reach to that position, you have done lot of unethical things. Believe me, don't do that. When I look back 30 years of my career, I'm tremendously happy that I worked with ethics. I never did unindicated surgeries. I have always tried and given what best I could give to my patient. So your reputation matters, Ritu. Your reputation gets built, your character is your strength, which is built up over years. You cannot build up your strength or a character overnight. So work hard, dream big, look at the sky, what you want to see, and then work hard to achieve that.
Thank you. Thank you so much, ma'am. Thank you so much. Thank you so much, ma'am. And madam is contesting for the president election this year. So ma'am, all the best wishes to you and all the support from the academic buddies group from our side. So ma'am, all the best wishes for your success for your.
Thank you.
Yeah. Thank you once again, ma'am, for
sharing. And next time we have a hysteroscopy simplified. Let's have only video and every video I'll explain. Yeah.
Okay, ma'am.
I'll enjoy that, Ritu. Thank you.
Okay, ma'am. Thank you, Shield Pharma, for providing the platform. Thank you, dear buddies. Those all have joined. And next Thursday, we are having Sheila Tanna, madam, is with us. She is going to discuss with us a very important topic, the post-menopausal obesity, how to tackle. All the practical points we are going to discuss. And on the 13th, we are having the Dr. Gitendra Sharma with us, again on the medical legal. Later updates, I will update. Yeah. Till then, bye-bye. Good night. Yeah.
Thank you, Ritu. And thank you for the opportunity.
Ma'am, it's my pleasure and honor, I can say.